Good evening, sir.
Good evening. Good evening, my dear.
Yeah, so again, one more daily dosage today for neurosurgery during this lockdown. And we have Professor Goel with us. So we've been watching his videos, and some of these videos speak about his spectacular experience as well as his operating philosophy, which is very, very different from a lot of people. I can only say that we are fortunate to have him on this daily dosage. And Parthiban's talk also, I was listening to it, and I am generally not somebody who's interested in spine at all. Probably haven't operated spine for the last 4 or 5 years, except in very, very rare cases. But then Parthi's clear explanations and the way he is explained is excellent. I'm sure the young neurosurgeons are enjoying it. And of course, no introductions needed for Professor Goel. So please, sir, take the stage.
Okay, thank you very much. Today I'm going to present a real revolution for you. And I am sure you will enjoy it, even if you don't like spine. I must tell you, do you have my screen, John?
Yes, we see it.
Okay, let's begin without any further ado, my dear friends.
Okay. A little slowage on his network. Just wait. Be patient, everybody. It usually comes out of this okay. Okay, he'll be back on momentarily. Whoop.
Okay. So.
Hey, you fell off the screen chair, Doc.
Yes.
Yeah, there you go.
So I am going to present to you a spinal revolution. Now you will ask me, what is this revolution? Is this word a little too much? That you have to decide after I finish today. And this is part 1. I am going to have 4 or 5. So part 1 for today. And I can, just a minute. Part 1 for today, okay?
Okay.
Spinal surgery revolution. Just a minute. So we have to move, we have to fly, we have to do several activities like this eagle, and movement is life. But human beings are different than this eagle or this vulture, I don't know what it is. You see, when the vulture flies on its beautiful wings, and you see the majestic fly, pressure on the spine when the vulture is in air. So this is a very unbelievable kind of movement that this vulture has. And then you have a beautiful horse. You see the various muscles of the horse. and it runs on his 4 legs. So the spine is supported by 4 legs, and human beings are the only mammal, other than some gorillas maybe, who walk all the time on 2 legs. And this majestic horse is extensor predominant. And the center of gravity, center of activity, you see this beautiful horse. And when the horse stands on 2 legs, at that time it is 0 center of gravity. Extensor muscles are prominent. Extensor muscles are active. Flexor muscles are passive. All the movements of the horse are extensor active and flexor passive. So as I showed you, to bring out this concept as to what I am going to talk to you, I am going to come back to my very favorite slide of human pillar. Human pillar is a very unique pillar, and we stand on 2 legs. And this is our craniovertebral junction. And this entire spine is standing on very small focus point. So this is the human spine, and this is the atlantoaxial and occipito-atlantal joint, or the craniovertebral junction, and this is the rest of the spine. The whole human spine is extensor prominent. It means all the movements of the spine are conducted by the extensor muscles of the body. If you touch your neck from behind, there is a huge bulk of muscles, and there is not a single muscle anterior to your spine, except for very thin longus colli, which has a function of a curtain rather than function of an activity. The function of a curtain is to prevent showing what you are doing. On the other hand, the extensor muscles are the ones that perform or do. So all the muscles, despite the fact that there is body, there is disc, but very little muscle anterior. All the muscles are lateral, and all the bulk of muscles are posterior. So instability of the muscles, instability related to your muscle weakness, is the bottom line of your problems. There is no embryological issues in atlantoaxial instability. It is the muscles that make you unstable. An atlantoaxial joint, which is the most mobile joint of the body, can become unstable early in the life. And this instability has to be treated, if you have to treat, according to my understanding, from behind by sectioning all the muscles. If you have to stabilize C1, C2, you have to section the muscles. Unless you section the muscles, any implant put from front can be very heavily neutralized by these muscles. So this is my principle and my understanding, not to say anything about beautiful presentation of Parthiban. Essentially, all the activity is from behind in life, and the activity of surgeon is also from behind. So this is the technique that we had proposed for atlantoaxial fixation. Basilar invagination, we had proposed that it is due to atlantoaxial instability. I must tell all the listeners that this concept, which I am talking to you repeatedly, has not yet, was never understood before 15 or 20 years. Instability was not at all an issue in basilar invagination. So we introduced for the first time that basilar invagination is an unstable phenomena, and it can be treated by lateral mass fixation. So this is an issue of atlantoaxial instability is the issue, and stabilization is the treatment. This concept was never there in the literature. So this is quite a revolution in spine surgery. That is why somebody was asking me about decompression, and so I have said that decompression or removal of bone is not a treatment of any craniovertebral junction instability related issue. Like this is the problem. This is an unstable spine. You stabilize atlantoaxial joint. If you cannot, then you have to learn. You cannot say, I will do decompression because I cannot do it. If you cannot do it, do not do. But there is no excuse of doing a wrong operation. If I say I do decompression, then it is a wrong operation, and that you have to realize. I'm not trying to criticize anybody. I'm not trying to say anything about what others are doing in the world. And I am saying on a same eye contact level with all of you, even if you are residents in neurosurgery. So this is a huge basilar invagination. It can be reduced. So our concept was that all basilar invagination is an extensor muscle issue, extensor muscle related problem, and stabilization is the treatment, and realignment, if it is possible, is a good option. Listhesis, facet C1 over C2, like spondylolisthesis, we had said for the first time in the literature that basilar invagination is nothing but listhesis of C1 over C2. Like you treat listhesis, similarly you treat C1, C2 instability, and you see this is preoperative and this is postoperative in a beautiful alignment. Whether you get alignment or you don't get alignment, that is a secondary one. The issue is it is unstable, you stabilize. That is the issue. So facets are the strongest bones of the spine. Each vertebra, if you hold, they are the strongest facet. Vertebral body is the weakest. Spinous process is the next in line. Lamina is strong. Pedicles are quite strong. Facets are the strongest. There is no real muscle attached directly to the facets. There is no real muscle attached directly to the vertebral bodies. They are the fulcrum of the pulleys. They are not, the activities is there, but there is no muscle attached directly to the facets. I will show you this, what I mean. So facets are the key, and we have to learn the facts about the facets. So this was C1, C2 facet I have talked about. So there is nothing much attached to the facets. All the muscles are attached to the C2 spinous process, to the transverse process, and they relate and activate the C1, C2 articulation. This is the fulcrum of all movements. The facets is the center of activity, and the facets is the center point of the activity. And that is why facetal fixation as a mode of treatment we described for atlantoaxial instability. Now you see this slide, all the muscles are extensor prominent. As I had discussed yesterday about my philosophy of the disc is divine. Disc is the opera conductor. It conducts the whole movements without lifting any instrument in hand. It is like odontoid process. There is not a single muscle attached to the odontoid process. All the movements, this is the facet. These are the muscles, and these muscles act, these are the pulleys and act on the facets. So facet is the problem, not the problem, it is the site of activity of all movements. Disc is the conductor, conductor does not do any activity, but it is the brain of all movements. The brawn you can see, the muscles, brawn means muscle, B-R-A-W-N. So as I mentioned to you, instability is the cause of retroodontoid calcification or osteophyte formation. These are the osteophyte formation. For 20 years or 30 years, these were considered to be tumors, and these were considered to be abnormal, and these were considered to be pathological, and they were removed by transoral route or lateral, far lateral route, extreme lateral route. But we said that this is not any tumor. This is a response to an unstable spine. You do atlantoaxial fixation, and this will eventually disappear. So this is a landmark article of mine. And after that, there have been several further articles which said, yes, we have also found that the retroodontoid pseudotumor, as it was called, is not a tumor. It is a response. It is an osteophyte. It is due to buckling of the. Now, another statement you listen, which first time we reported in the literature, that when there is a listhesis of C1 over C2, there is buckling of the posterior longitudinal ligament, which initiates a bone formation phenomena, or like a callus, periosteal reaction kind of phenomena by separation of the periosteum from the bone and this bone formation. So, see, instability or instability is the primary problem. These are secondary, and in one of my articles, I had said that osteophytes are protective phenomena. They are not pathological. So this was my article in 2004, which I consider quite a revolutionary article, stating that atlantoaxial instability is the cause of retroodontoid mass. Then subsequently, we reported several other articles, including retroodontoid cyst formation, which we said is due to buckling of the posterior longitudinal ligament. You stabilize and distract, and this can go in the immediate postoperative period, and there is no need to remove this so-called buckling and cyst formation in the retroodontoid area. So there can be a possibility of immediate postoperative disappearance of retroodontoid pseudotumor, as it was called. And subsequently, we have got several other papers. So this is another retroodontoid cyst, and you see this cyst is completely gone, and this is fixation. No attempt was made to touch this cyst, even if it is a very simple operation, but it is not necessary. So that is the philosophy number one that you must remember. Even as I had told you that this pannus is due to severe unstable atlantoaxial joint and buckling of the retroodontoid ligament, which we used to call pannus, and it was considered as pathological phenomena. So this pannus is due to buckling of the retroodontoid ligament and inflammatory response. So you do retraction and distraction and fixation, this pannus can be immediately gone. You see this buckling, and this is gone. Only distraction was done in this patient, and this is the. So we introduced long time ago in the year 2000, about 20 years ago, we introduced these intra-articular spacers for the first time in the literature. Intra-articular, intrafacetal implants were introduced by us in the year 2000, and I had labeled this technique as joint jamming technique. And I used these spacers for the treatment of not only atlantoaxial instability, as I have shown you the other days, but I had used it for the treatment of basilar invagination, rotatory dislocation, and several other issues in the unstable phenomena of craniovertebral junction. Now I will come to degenerative spine. So this was my article a long time ago, and craniovertebral junction instability due to degenerative osteoarthritis of atlantoaxial joint. You see, 108 cases in the year 2010. So this was the first time in the world literature that craniovertebral junction degeneration was described as in the first time in the literature. And we have described in such a huge number. So what I am trying to say is C1, C2 degenerative spine is a very common phenomena, although it is not understood. or it is misunderstood and misdiagnosed. So in one of the lectures, I had said that atlantoaxial instability in craniovertebral junction due to degenerative osteoarthritis is the most underdiagnosed and undertreated clinical entity in the subject of spine. You see, this is craniovertebral junction atlantoaxial joint. This is buckling of the posterior longitudinal ligaments, reduction in the joint space, osteophyte formation. So what we have said in our article, that joint space gets reduced due to vertical dislocation of the atlantoaxial joint. Vertically unstable atlantoaxial joint will reduce the joint space. It will initiate formation of osteophytes due to buckling of the posterior longitudinal ligament. So essentially what was described is that joint space reduction is not a primary phenomenon. Ligamentous buckling and osteophyte formation is not a primary process. All these are indicators of atlantoaxial instability. And when you see osteophyte, when you see joint space reduction, when you see buckling of the ligaments, it is a clear indicator of an unstable atlantoaxial joint, and you need stabilization. Bone formation in the region of odontoid tip is never a congenital problem. It is an osteophyte in the apical ligament, and it is an indicator of an unstable atlantoaxial joint, and it is an indicator for atlantoaxial stabilization. Do not try to unnecessarily disturb this odontoid tip. So when you see ossification in the region of odontoid tip, it is a clear indicator that this region is unstable. When you see osteophytes like this, it is a clear indicator of an unstable atlantoaxial joint, even when there is no deformation here. So that is one thing which is a revolution, I can say. Buckling of the ligamentum flavum that you see so often was in the entire history of this subject. Buckling of the posterior longitudinal ligament, osteophyte formation in the entire history of degeneration has been considered to be a pathological phenomena, but we said for the first time in the literature that these are not pathological, they are response to the unstable spine. Similarly, if you see the lumbar spine and cervical spine, if you see disc space reduction, this is a clear evidence of an unstable segment. Osteophyte formation, if you see osteophyte formation, it is a clear evidence of an unstable spinal segment. If you see disc bulges like this, these are not a primary pathological phenomena. If you see ligamentum flavum bulges, if you see disc bulges, these are not primary processes. They are indicators of an unstable multi-segment of the spine. So this is a revolution. This has never been described in the literature. So you please try to understand what I am saying. If you see the entire literature on degenerative spine of last 150 years, the first sentence in that literature survey will be that the disc space is reduced due to reduction in the water content of the disc. Space is reduced due to age-related disc degeneration. And then it leads to osteophyte formation. And then it leads to compression. So this is what is described in the entire 150 years. And still, if you see today, all the entire literature on degenerative spine is focused on disc space reduction, which I am saying is not a primary process. It is an evidence of a spinal degeneration. This is not degeneration. This is a secondary phenomena to spinal instability. Osteophyte formation, buckling of the ligament, disc bulges are not primary processes. They are due to unstable spinal segments. So we proposed a very novel concept. There is a vertical facetal instability. So this article of mine, I will consider it as an entire absolute revolution in the field of degenerative spine. That there is a vertical spinal instability, a problem that we are facing due to standing human position all our life and due to weakness of muscles of extensors, extensor muscle, erect spinal posture, weakness of the muscles leads to telescoping of the vertebral segments or vertical spinal. So if you see C1 over C2 listhesis, as we had labeled as basilar invagination, similarly, there is reduction in the facetal space and facetal listhesis, which has never been reported in the literature. Even this was never reported.
Okay, I think we have a temporary freeze. Just hang in there. Usually resolves in a minute or two if we're lucky. Okay, continue to wait. He'll come back. He always does. Are you there, Dr. Goel? Are you there, Dr. Goel? Okay, he'll be back. Still standing by.
Hey, John. Yeah, is the talk the Jordan Grand Rounds right after this, or is it
Yeah,
around?
it's right after this, and in about half hour.
Okay, fantastic. Just wanted to confirm.
Yeah. Oh, I might as well. I might as well make that announcement now.
Yeah.
Now that we have time, to everyone out there, we have a Jordan Neurosurgery Grand Rounds with Dr. Ibrahim Sabaya, a well-known Jordanian neurosurgeon and medical educator who has been doing these Abalash for 27 years. Before the internet, he was doing multidisciplinary weekly presentations, and now he's using the internet to get the Arabic neurosurgery world involved.
Yeah, I'm looking forward to it. I have a case coming up next week, so it's going to right up my alley.
Oh, really? Orbital tumors?
Yeah.
Oh, good. Yeah, you can interact with him too.
Yeah,
and you know, and then kind of brainstorm with him. So, okay. Well, maybe you can use this time to. Oh, here he is. Okay, Dr. Wells here. There he is back. He always comes back.
Yes, John, I'm there again.
Okay, okay, carry on.
You know what? These young people, I know they are getting troubled, but if you want to see something out of the world, then you have to handle this trouble. Don't worry.
That's okay.
Okay. John, now I start again.
Okay.
So we introduced a very novel kind of a surgical technique where we did facet distraction, introduce facet distraction spacers in the treatment of degenerative spine. So in this technique, there is no question of any decompression. I will show you. So facet distraction arthrodesis technique I am going to show you today, and can it revolutionize the treatment of spinal degeneration? So this technique is facet distraction arthrodesis technique. So this is a new philosophy, an alternative method. There is no alternative. This is the technique, and this is the revolution in the treatment. And when I say it is a revolution, it is not in air. It has been published very heavily. And you see it was published in the year 2011. And before that, in 2010, it was also published on the pre-print publication of this Journal of Neurosurgery. So this is not a technique which is just in air. It has been heavily published, and also it has been quite heavily followed in the world. So those young people who are having a feeling that this is some kind of a hypothetical treatment, you please remove that from your mind. Many people in the world, and if you go home and see later the literature on this subject. So this was the revolution that I am going to present to you today. And this article of mine was published as a cover page of Journal of Neurosurgery. It was on the cover. And these are the spacers that we had introduced at that time. So if you hold the vertebra in your hand, and there are several articles of mine on the morphological, morphometric analysis. You see, this is the huge facet. It is the strongest part of the vertebra, and it is obliquely inclined, like this oblique inclination. And we had measured all the inclinations, and this is the vertebral artery in relationship. All kinds of morphometric measurements were done by us. So those who want to go further in this technique must read several of these articles where morphometric analysis of the cervical facets has been described to introduce Goel. We had labeled them as interfacet spacer distraction technique. So this was another paper for lumbar spine. So this was, if you realize, this was for cervical facets, and this was for lumbar facets. So now here you see these are the very big and strong facets. So this standing, my concept was that this can never go wrong. It is a divine structure. This is divine. This is an absolute miracle of body. What happens is the human body is not used properly. It is abused, misused, or malused, or injured. When these muscles, which are focused on the fulcrum point of the facet, this becomes weak and the facet dislocates vertically, or vertical instability of the facets. So there is vertical instability of facet. This cannot be seen on the conventional CT scan or conventional MRI, but basically you have to understand, you may not see this, but the effects of this instability is the osteophyte formation, the buckling of ligament, and the reduction of the disc space. And we introduce these kind of spacers. After, you see, this was the normal. Here we have, this was the abnormal one, and I have distracted and introduced this spacer. And I have realigned the facets. So this is what I'm going to show you. See, this is the osteophyte. This is the joint space reduction or disc space reduction. This is the ligamentum flavum buckling. So what I had said for the first time in the literature, that this buckling is not primary. This ligamentum flavum is not primary. This is not pathological. This is not a disease. This is not a disease. This is not a disease. This, of course, can never be diseased. You do distraction and you can get a new disc here, and this ligaments can unbuckle, and this ligament can unbuckle, and most importantly, and more importantly, the patient will remarkably recover in the symptom without any decompression. No laminectomy, no ligamentum flavum removal, no osteophyte removal, no disc removal. If you ask anyone in the audience, this is a very clear case of single level ACDF. You come, remove the disc, osteophyte, and then do whatever you have to do. But this is not the treatment. This is a wrong treatment, because what it needs is distraction, reduction, and fixation by this kind of goel facetal spacer. This is another case. You see the osteophyte, you see the disc space reduction. These are clear indicators of an unstable segment. And when this is unstable, you have to do fixation and you have to do insert intra-articular facetal distractor, which is the most physiological way of achieving the distraction, reduction. And you see the disc space has a little bit increased, and eventually these osteophytes will disappear. This is another case. You see the osteophyte, very big osteophyte. You see the buckling of the posterior longitudinal ligament. You see the buckling of the ligamentum flavum. This is post-operative. The osteophyte is gone. The ligament. This is immediate post-operative, and you see a new disc is formed. Disc is what? Water, and this T2 weighted hyperintensity in the disc space is a new disc formation which gets formed. Multi-level disc degeneration, I do not like this. Disc degeneration is divine. Disc can never get degenerated, but this is in our mouth. This is all the time.
I'm sorry.
You see these fusions is never primary. It is never primary. It is an evidence of an unstable spine. Treat. You see this osteophyte. This is Hello, John?
Yeah, go ahead. I had to unmute everybody. Okay. Go ahead.
Okay. Now, if you see This joint space reduction or disc space reduction, osteophyte formation, these are divine interventions. These are not to be touched. These are introduced by God. Don't try to be against God. God is on our side. It is a repair machine. It makes you, it can repair you without any problem. You see the interfacetal space and you see the spacer, and you can imagine how the space in the root canal will be increased, in the spinal canal will be increased. You just keep your open mind when you are seeing this. You see this? These are unstable spine. Now, how to identify this unstable spine? That is on your clinical parameters, radiological parameters, and you see there is joint space is increased, and these are spacers, and ultimately this will lead, this is some bone, and ultimately this will lead to bone fusion. You see this multiple, and these are 3-level stabilization, and these are intrafacetal spacers. Preoperative, you see unstable facetal articulation. This is another spin, multi-level, degeneration, multi-level divine intervention for unstable spine. And you see this immediate post-operative, you see this is not yet gone. This hyperintensity in the cord may not go, but you see this one and you see this one. Most importantly, the patient will remarkably recover in the immediate post-operative period. So this is multi-level spinal degeneration, also associated with OPLL a little bit. I will talk about OPLL in my revolution number 3. Today is revolution number 1 I am talking about. So this is intrafacetal spacers at 4 levels. Intrafacetal fixation is the treatment. Stabilization is the treatment. Decompression is not the treatment ever. Believe me, decompression is never the treatment. You please remove it from your psyche as decompression. So this is buckling of the posterior longitudinal ligament. This is immediate postoperative. I will show you. This is another case of buckled posterior longitudinal ligament. This is postoperative new disc formation, and this ultimately what has happened is not a radiological cure, may not be there, but this has been stabilized, and that is what matters more. This is stabilization of this area. This is post-operative. You see this is pre-operative, and this is the spacer in the facetal articulation. This is the spacer in the facetal articulation, and you have seen. Now another thing, you see there is a buccal posterior longitudinal ligament. The whole world, an entire lot sitting in front of me in the panel will come from front and remove this. I was doing this thing all the time, but this is not necessary. Facetal destruction is the treatment. Stabilization is the name of the game, and immediate postoperative reduction of the herniating disc as well. I will show you better images after some time. This is pre-op and post-op. You see the disc space has increased, the intervertebral spaces are increased. More importantly, the spinal canal is increased and the neural canal is increased. You see the space here, and you see the space has increased. Articulation, there are spaces. You see this foramen is increased to a tremendous level, and intraspinal volume is increased to a great level. This is another case. You see pre-operative, there is a facetal space reduction, and this is after 1.5 years. You see there is arthrodesis of this joint T1, this whatever joint is there. Bone, this is the facetal articulation. There's spacer here, and this is the bony fusion that you are seeing in the space. Fusion is the answer. Arthrodesis is the answer. Decompression is a redundant or a negative form of treatment, either from front or from behind. So this is my philosophy, and this even with 3-level fixation, you can have a good spinal movement. Now you see this is pre-operative. After 1 year, we have put this spacer, and you see this bone fusion after 2.5 years, and you see this bone fusion. This is pre-operative osteophyte, And post-op, this after 2.5 years, you see the osteophyte is disappeared and there is a bone fusion in this territory. This is the osteophyte. You are seeing multi-level osteophyte. You see the osteophytes are gone. And this is after 2 years. You see there is no decompression, and there is no compression. So this is what I have to give you, this message that decompression is never, never, never an answer for degenerative spine. You see this is preoperative, and this is after 2 years. You see the spacers and you see the bone fusion. If you carefully see, the spinal canal is increased in spine, increase in size, root canal is increased in size, and the patient has completely been cured. This is another patient. You see the bone fusion here after 6 months, and after 2 years, there is complete bone fusion. And you see that there's reduction in the joint space, opening up of the joint space, fusion. You don't see this articulation. What you see is the root canal, which will be increased, this space, which will be increased. And more importantly, the region will be stabilized for you for complete arthrodesis. This is, you see, preoperative multi-level bulges, not this multi-level divine intervention of osteophyte, indicators of unstable spine. And this is after 1 month, you see the osteophyte is completely gone, and you see the stabilization, no decompression, and this is the treatment. This is another one. You see multi-level spinal degeneration. Oh, what degeneration? Multi-level spinal divine intervention of osteophytes and multi-level degeneration. You see the new disc is formed here. Ultimately, there will be arthrodesis, and there is a big space for the spinal canal. This is another case. You see multi-level divine intervention by disc space reduction, and you see that disc space has been increased. Osteophyte will eventually decrease in size, and there is an increase in the spinal canal dimension. You see there is quite a large osteophyte, and this is the one. You see osteophyte is, this space is increased. Can you compare this and this? Quickly compare, and you see there is no compression to the spinal cord. This is another case, beautiful case, beautiful case. You see there is increase in the joint space, increase in the joint space. There are intra-facetal spacers. There is no decompression. You see this another case, there is a osteophyte, divine intervention, and this is human intervention, and this is the reduction in the osteophyte after a period of time, and there is, of course, ligamentum flavum unbuckling. And now you see a beautiful case, my dear young friends, and believe me, keep yourself, don't argue with me unnecessarily, okay? Don't argue. Don't forget about it. Do whatever comes in your mind and has been, but if you keep your mind supple, you better keep it supple. If it is not supple, forget about it. Okay, what I'm saying is don't even think about it. But what I'm showing you is a complete revolution, and it is eventually going to take over. So better you understand it now. You see divine intervention here of ligamentum flavum buckling, osteophyte buckling, and this is post-operative. You see the entire ligamentum flavum gone, buckling is gone, and the patient remarkably beautifully improved in the immediate post-operative period, and you see intrafacetal space. There can be immediate post-operative. Whatever I'm saying to you, dear friends, is all published very heavily, and several people in the world are doing this. So don't think it is, don't try not to learn or forget, hypothetical, this kind of nonsense. There can be immediate post-operative reversal. I have discussed this article long time ago. I have shown you this image. This is immediate post-operative finishing of this by introduction of these intrafacetal spacers. You see this large divine intervention, and it is gone. Ligamentum is proper, ligamentum flavum is beautifully, and there is a beautiful arthrodesis of this segment of the spine. So these were my facetal intra-articular spacers, and these are the spacers. This is a concept, and there is emergence of the concept. We had introduced this concept 16 years ago. Don't think that it is a brand new concept and I have just come and suddenly I have got an idea and showing to you. And also it is my patent. In America also it is patented. You see, there are 2 patents of mine on this subject. It is not only the implant, which is, carefully read, device and method. Device is also patented and the method is also patented in US. Now you carefully see my implants, which I have labeled them as Goel Facet Spacers. Company Jesco is making in India. The CEO of Jesco company, and he can work out this thing for you. I'm not trying to do any kind of a commercial things on you, but just see what I'm showing. And this is also patented in India, and this is the patent certificate. There are 23 patents of mine in India, and you can go through this patent certificate. So this is my design of my patent. Outer diameter is this much, this height, this height. There are multiple kind of sizes of this facet spacers. This is the front view, lateral view. There is a hole here for the implant holder, and there has been, this is the facet spacer in the spine, which has been heavily biomechanically assessed and learned. So same concept I have used in the lumbar spine and introduced intra-articular facet spacers in the lumbar spine on one segment and multiple segments. And this was also published in the Journal of Neurosurgery. So it is distraction of facets with intra-articular spacers as the treatment of lumbar spinal canal stenosis. And this was another article which we had published on the subject. And this is biomechanical studies on the subject were carried out in one of the world's largest biomechanical institute in Toledo. And they had studied the biomechanical properties, and they have, you can read this article where they have said that this spacer is better than any other implant in the spinal fixation constructs. This is another biomechanical studies. They have studied the lordosis, height, and all those things, and they had come to this conclusion. So this is my relevance of my hypothesis regarding pathogenesis of degenerative spondylosis and its implication in facet distraction surgery. So this is my revolution number 1. I will come to you, my revolution number 2. I will give you some time for digesting this revolution first, so I will not land up with you tomorrow, maybe after 1 or 2, 3 days.